Thank you very much for this opportunity, which I really enjoy, and the importance of this meeting is underlined by the fact that we have in one room, which is quite rare outside of Europe, a former president of European Society of Cardiology, plus the acting president and the incoming president. So I'm pretty honored to give my also philosophical views on interventional cardiology and the science that's produced from it and share it with you. Now, let me just, hand to you that you have to interpret the scientific data by applying what I call a conversion factor. And this goes mostly to the younger people here in the room. The more seasoned ones among us, they do that intuitively. We assimilate everything we read by our own experience, by also where the publication comes from, by how we publish ourselves and so forth. Now, how can I explain that? Now, if you have a comparative trial, even randomized, showing a new thing and an old thing, and and now you have 80% success with the new thing and 70% with the old thing. That's how it's going to be presented in a good journal. But you have to know that, of course, the authors are very compelled to show the new thing as a good thing, because that's maybe their invention, or at least what they like to propagate. So you have to kind of evaluate a little bit the results of their new thing. But that's not the end of it. The old thing, of course, they have all interest to make the old thing look a little worse than it really is, to make the difference more conspicuous. So the old thing may actually be a little bit better than it is described. So what you actually should read out of this paper is exactly the opposite of what is written there. Now, let's say the difference is really quite huge, 90% versus 70%. Again, keep in mind that the new thing is going to be presented a little bit better than it really is, so it may be 80% real success. And the old thing has been made a little worse to make the difference look a bit more conspicuous, so it's probably just a draw and not much to write home about. Now, if the results are presented like this, we would say it's a neutral study, but in fact, actually, it probably again means that although trying, to make the new thing a little bit better, the new thing actually is only a bit like this, and trying to make the old thing look a bit worse, it's actually better than it's shown here. You actually have a pretty bad new thing, and you shouldn't really even think about it twice. Now, of course, if it's already presented as a negative trial, you already know that after all the conversions that had made, it's a real negative trial, and I wouldn't touch this new thing with a 10-foot pole. Now, let me just go back to interventional cardiology, which we think, of course, is mainly coronary interventions. That's true in terms of numbers and industry created by it. I all owe it to my tutor, Andreas Grünzig. Most of you have known his face. And of course, he died very young, which is a tragic thing, because he could have contributed many more things to cardiology, but it's also kind of unjust, because we remember him as a splendid, a good-looking young man, and by now he would be 76 years of age, and this is just a hypothesis. I can only speculate, together with also late Richard Meier, what he would look like today. One thing that he also taught me, and is going to teach all the young people here through this picture, is when you propagate something, you have to believe in it. And he was propagating early coronary angiography as a screening instrument, and he was also, of course, very convinced about having PCI being the good thing. Now, when he was 45 years old, by the way, a year before he died in a plane crash, he just said, I want to see my coronary arteries. So it was actually the evening before the Christmas party at Emory University. I'd already left the team at the time, when he said, I want to see my coronary arteries, do an angiogram on me. And you see him at the end of this angiogram, which turned out to be normal, and you can see that he was completely stress-free, which I cannot say about the guy who did the case. As you can see here, there was a bit stress on his side, but and then he got up. This was in 1984, and he went to the Christmas party. So it was done femoral, of course, at the time. So as you can see, that outpatient angiography for no good reason was already a fact, thanks to Grünzig, who believed in this technique. Now, you all remember that by the end of the 80s, there was first the Canadian group by Campo and from Montreal, and then who propagated to do diagnostic corneal angiography through the radial artery. And then Kimeney in Holland took it up and said also PCI can be done. And to make a point, because he knew that I was really an amateur of simple things, he said, why don't you do that as I do it? You see it on the Amsterdam market here. I offer my PCI. And you can see there's really no problem. This guy just had it and is quite happy. This guy is just having it. This is, by the way, Kimeney himself who put that up. And this guy is waiting for it, and there's a lady and another guy. So it's a very simple thing. And this is Ferdinand, how he looks today. Also, he has aged a little bit. But as we all know now, his idea from there actually is quite popular now after some time, and I'll show you why. I also tried it at the time, but then I gave it up again because it was much more complicated. You needed all this paraphernalia to do a radial coronary angiography or PCI, whereas the femoral just needed this needle, and that was it. So I thought I went back to femoral after giving it some try. Now, you all know that the popularity that we see now, I have to say that some French people particularly, and Canadian people and some Dutch people continued with radial and were convinced that this was a good thing all along, but the rest of the world turned away from it and came only back when some clinical data were published showing that actually you have a better outcome, particularly in acute interventions when you use radial, something that does not make sense to me, frankly, because if it's really time is of the essence, you're in a hurry with a transmural infarction, go femoral because you save maybe 5 minutes, but 5 minutes is already something if you have half of the heart at stake to be about to necrotize. And you can see that this trial, the Matrix trial, which was published, of course, quite prominently, actually showed something that again, you have to apply this conversion factor. You can see that the centers in the Matrix trial who had a low habit of doing radials and did it just for the randomized trial, so no difference. Those who had an intermediate habit, so no difference. The only part of the study who made the difference were the aficionados of radial, those who really wanted to bring the gospel, you should do it radial, and they made the difference, and you know they were biased. So I have my doubts about whether there is really an advantage of doing a radial in an acute coronary syndrome. And again, showing how you have to sub-interpret data is here. When you look at the bleeding, which is the main advantage, of course, you can have a big bleeding in your radial artery. We all agree to that, but you can theoretically die from a femoral puncture if you get a retroperitoneal bleeding, which you shouldn't. If you puncture below the femoral crease, you will never get a retroperitoneal hematoma, but still from the arm you can really not die from a bleeding, that's for sure. So bleeding is basically the essence between femoral and radial. And if you see here, this trial was showing that the radial bleeding when it was compared to femoral, where it had to make a big difference. And then this trial shows the bleeding when actually it was not a comparison femoral radial, but a comparison between using bivalirudin or heparin. And those were practically all radial artery angiographies. So all of a sudden, when you want to make another point, all of a sudden our radial arteries have a 10% bleeding rate, and before they only had 2%. So just to sum up my opinion on radial, it's a very elegant. The patient can walk out of the cath lab, and so, which they don't do after myocardial infarctions, but in elective case, it is elegant. But I'll show you why I don't think it should become the standard. It's femoral is like driving a normal bicycle. Now radial is more like driving a motorcycle. Everybody can learn that, but it's a longer learning curve and it's a bit more shaky. So if it comes out to bring out pizza, oh yes, you can do it on a motorcycle, but I submit to you, use a normal bicycle, it's going to be better, particularly if the terrain gets a little bit more difficult. It's much better to have a bicycle than to have a motorcycle. And this is why I think that difficult cases in particular, or acute cases, should be done femoral. Unless you haven't done any femoral for 10 years, then of course you should do it radial. And this flatter and longer learning curve, with the motorcycle, it's yourself, who's going to be falling off and get all the, the sequelae of the crashes. If you want to do a motorcycle rather than a bicycle, you can learn it and you can go to work on a motorcycle. But with radial rather than femoral, it's actually the patient who pays the price, during the flatter and longer learning curve. If everybody thinks, now I have to learn radial, the patients are paying the price for it, and I think it's not right. And actually, we have to keep in mind that you are going to lose some of these radial arteries. Now the surgeons no longer are so keen on them. If a patient doesn't have one, that doesn't mean that bypass surgery is going to be more complicated, because they rarely use the radial. But still, it's not good to lose one of your two arteries to your hand just because you want to do a more modern kind of intervention. And this loss is actually, if you're looking at some studies, 2% or even up to 30%. So informed consent for a radial should actually read like this, and it does not, nowhere that I know this is mentioned in an informed consent. So you should actually tell your patient by writing, the access to your vessel will be at the wrist radial artery. This carries a risk of 5 to 10%, and that's on the lower part, that your artery will no longer function because of the procedure. And if somebody has to sign that, I'm sure there will not be that many candidates any longer for a radial artery. If you do radial artery, by all means use small catheters. It has been shown that just going from 5 to 6 French, which if you use a sheet, that means actually going from 7 to 8 French on the outside, you more than double your occlusion rate of the radial arteries. And I used to make this when we were coming down with the French sizes in the femoral approach, but I can still use that, how many French do you really need to do a PCI? And I used to say that the only reason to use more than 5 French for a PCI is if it is done by a French, that would then make 6 French altogether. So if you go radial, go 5 French for all sakes. And of course, if you go sheetless, that means you're not 7, but you're really 5 French. Now, other new things have come up, during the 80s, during the 90s, and those new, so-called new devices for cornea angioplasty, sometimes we thought that what we had, before stents was really not good. We were Dr. PCI Hart was a bit lost on this island. And then he saw, a new device coming on the horizon, looked pretty good, and he got all excited about it. But once he had it in his hand, once he had it in his hand, it did. Sorry, okay. Let's go one more time here. Once he had it in his hand, as you just briefly saw, it didn't turn out to be really helpful. Okay, now, while those new things came up, the more critical people like I was at the time, we're really looking at them. Are they really an improvement? Although, again, they were shown like being so much better than the old thing. And I used to kind of tell my colleagues, maybe this new thing that you're so excited about is not really so good. I used this fairy tale from Denmark. Christian Andersen wrote this fairy tale where a tailor came into town and told everybody, including the emperor, that he was expensive, but he could make a robe that was the best robe in the world, the most beautiful one. There was just one problem with that robe: only intelligent people would see it. So the emperor, of course, thinking he is very intelligent, said, okay, make one for me. And when he got this robe, paid a handsome fee, but he didn't see anything. But he couldn't admit to that, because he said, I cannot admit that I'm not intelligent enough to see this robe. So he went in front of his people, all naked, and nobody dared to say that he didn't see the robe, because they all knew if you're not intelligent, you don't see it. Only a child, was very innocent, said, well, he is naked. And this is what we have to do from time to time. Don't try to stay with the people and don't just think, well, maybe I'm not doing it right and the technique is good. If you think it's not good, say it out loud. So from 1977, the first coronary angioplasty, we all know that it increased in popularity, and then there were all these new things. Actually, in the United States, everybody got crazy about atherectomy and laser. In Europe, we got more interested in stenting. And the Americans were not very interested in stenting, because what they did, they looked at the results of stenting and they saw there were lots of myocardial infarctions and even deaths after stenting, whereas with their elective laser and atherectomy, they didn't see that. Now, this was a misinterpretation of data, because stenting was only used after a problem had already started. When the artery closed abruptly, then stenting came in, saved a lot of lives and saved a lot of infarctions, but there is still about 20% of those patients did not do well. The other things were done electively, and although they finally turned out to be worse than balloon angioplasty, they looked much better than stenting. So I tried also to convince our American colleagues that laser was not really a good thing after I tried it and really couldn't find any advantage. So I made this slide here. You see Dr. Kath offering laser angioplasty. How would you like your artery, rare, medium, or well done? And it turned out that this was about what was offered. So we all know that from then on, things went as they should. Actually, they didn't, because what happened is stenting now became the default procedure. That was not good either. So I had to kind of turn around with others and kind of, try to calm things down and say, not everybody needs a stent. Whereas the other things then disappeared, which was okay. But the default stenting was not really what should have come, because there was a randomized, sometimes we get a lag. There was a randomized trial, again, by the way, published by Kimenei, which showed that if you use the initial bare metal stents rather than balloon angioplasty, actually your outcome at several years in terms of death, cardiac death, and Q-wave myocardial infarction was not significantly, but still quite worse than if you use balloon angioplasty alone. So actually this showed that default stenting was not a thing you should have done, but this was published in 2001 when default stenting with the bare metal stents of the time was already a fact. So even though I told people with others, of course, why would you stent everybody if before stent 70% of the patients never had a problem? They had no abrupt closure, no restenosis, so they had a perfect clinical result. Here a stent can only do harm, and initial stents did do some harm, as we all know. So I try to convince people that 100% of stenting is absolutely wrong. Probably you should stent 30%, or maybe not even, because of those 30% who have either restenosis or abrupt closure without the stent, not all will be salvaged. So actually the ideal stenting rate calculates out to be about 25%. And actually, this is exactly what was shown in this paper here. What they did is they looked at all the randomized trials, randomizing bare metal stents at the time against balloon angioplasty, and looked at the reduction in need of reintervention as just one of the endpoints that was achieved by the stent. And what they came up with as a conclusion, looking at this curve here, is exactly that about 20 to 40% of people should be stented to achieve the maximum. You see, to achieve the maximum or the minimum of need for intervention. Already at the 20%, you actually had plateaued. If you were going on to stenting 100%, you gained nothing. Now look at this. This is bare metal stenting It's even provisional stenting because only about 20 to 40% need to be stent, and you see that the reintervention rate was about 5%. Now keep that in mind. This was bare metal stents. Now came the drug-eluting stents, which actually were reducing the need for reintervention. Now, how can you show an improvement if already you're down at about 4 to 6% of reintervention? So what happened again is the same thing. You know, the same. At the time, the best probably bare metal stent, the BX Velocity stent, had been used to compare first against balloon angioplasty, and it had been shown that the restenosis rate was actually pretty low because it was compared to balloon angioplasty. So it was the new bride. It was, of course, made to look much prettier than the old bride. Now the same stent, the absolutely same stent in the same patients was now used as the old bride to compare against the drug-eluting stent. And all of a sudden now the restenosis rate was 23%, 37%, 43%. Why was it so low before and now like this? Because now the new bride had to look good. And the new bride had a restenosis rate, the drug-eluting sibling of the stent, of about 6 to 9%. If you had compared this to the initial results of the comparator, nobody would have been excited about it. So again, this mechanism worked quite well. And it even got so ridiculous that people forgot about what they had published earlier. And they also tried to make the Cypher stent look very good. So they said binary restenosis with the Cypher stent is like this, and with the BMS, it's 45%, you know, the bare metal stent. Now 45% with another bare metal stent, Palma Schatz, 36%. And with the balloon, they forgot that the balloon had been the ugly child at some time. They came up with 30%. All of a sudden, it's no longer important. Things are presented completely differently. So I put it like this: a lie is the truth until it is replaced by a better lie. And that sounds a little bit bitter, but it's not bitter, because I think that the truth is really too small a place to build the world upon. We need a little bit of voodoo, a little bit of excitement, otherwise we start doing research, and that would be a bad thing. But of course, reading research, we have to keep all this in mind. Now the thing went on, the stent saga, as I call it, went on. I told you that I was not in favor of stenting everybody with bare metal stents, because now we had this problem of late thrombosis. You know, before stenting, you had a lot of acute thrombosis, a lot more than here, so the stent salvaged some of these acute thrombosis here, but it got in late thrombosis. Without stent, there were no late thrombosis. Once the patient had left the cath lab or the hospital, heparin had stopped, the vessel would never go down. It restenosed, but it did not thrombose because it had new endothelium that was not thrombus prone, couldn't have erosion or plaque rupture. So it was not vulnerable, if I can still use this term after Peter Libby's talk. So now we had traded in, you know, these problems by gaining some in the acute phase, and as we had seen by Kimenei's study, actually these problems altogether were a bit worse than what we had salvaged by the stent. Of course, we were all glad to have the stent, because to have the patient go down in the cath lab was a terrible thing, needed to send him to acute surgery. The stent salvaged this problem, but it brought in later stent thrombosis, for which we didn't feel so much responsible as for the acute problem. Now, when these drug-eluting stents were heralded, of course, we and others said, now that we're going to make this coat, you know, the endothelial coat even thinner on these stents, we will have less restenosis in the stent, which is a good thing, because in-stent restenosis sometimes is difficult to treat, but we'll probably have more late erosions of this thin coat on the stent and have late stent thrombosis. And this is exactly what happened. You can see that the initial drug-eluting stents, they clearly have more stent thrombosis here late after 1 year than the bare metal stent. But what was completely ignored, and much to the detriment of the patient, was that they had fewer acute thrombosis. apparently the polymer on these drug-eluting stents was kind of like the Teflon coating in the frying pan. Acute thrombosis when they were still naked was less common, but nobody talked about this. They only, this 2006 firestorm against stents only looked at this time window here and said it's terrible, those stent thromboses where we only had very few before. So this led now for more than a decade to a completely wrong usage of drug-eluting stents. Because if you look at this curve, the initial, the worst, let's say, drug-eluting stent was the paclitaxel Taxus stent. Had this acute stent thrombosis here, and then going on of late stent thrombosis up to 4 years. The Cypher stent, also first generation, a little less prone for late stent thrombosis, but still kept on having late stent thrombosis. And now, of course, we have these modern drug-eluting stents, and they don't have this bane any longer. This blemish is gone. So it's very rare that you get late stent thrombosis. You still have some acute problems. Now, the bare metal stent always was like this. It had more acute problems in the first year, and then it crossed over with the paclitaxel stent, kind of. There was a catch-up with the sirolimus Cypher stent, but there is no more longer any catch-up with modern stents, so there is absolutely no indication for any bare metal stent any longer. And there actually was never one for a bare metal stent when the patient could not take antiplatelet therapy or needed surgery at month 3. The patient should always have gotten a drug-eluting stent, even with the first generations. But even nowadays, people get bare metal stents because of some fear that they might thrombose in this time area where every bare metal stent is much more dangerous than a drug-eluting stent, irrespective of what antiplatelet therapy you use, because some of these trials are randomized. This explains why this is like this. So the top picture shows you the sirolimus eluting stent had a very thin coating. It was too thin, so it was prone to erosion at 1 year and then caused thrombosis. You see, homogeneous but too thin. You could see the stent strut. The Taxus first generation had kind of lice and fleas because it had very thin coating on the stent struts, but in between the stent struts there were some hills here, so there were restenosis and erosion and late stent thrombosis. Now with the more modern drug-eluting stents, this homework has been done, and now they have a fairly thin coating, so they still have no restenosis, and they are no longer prone because the homogeneous coverage of the stent struts to late erosion. And the bare metal stent, as a comparator here, of course, had restenosis because the coating was too thick, but had no risk for late stent thrombosis because all the struts were covered. So it's quite easily explainable. Now people say that PCI or stenting cannot save lives, only surgery can, but that's not true. Because we're selecting the more simple coronary artery disease, it takes time for coronary artery disease in a mild form to kill the patient. Fortunately, it does. And this was shown by the Munich group that you have to look at a follow-up of 5 years or even longer to finally come up with a mortality benefit if you do PCI. Wait long enough and you will see it. And interestingly, we see now exactly what we went through. You see that if you look at mortality benefit of bypass surgery against medical therapy, that's an established fact if you take, triple vessel disease, left main disease. Now the balloon came close actually to this, but then things got worse. When the stent came, it moved again to the right side, so there was less mortality benefit against medical therapy. The first original deaths also because of this late catch-up phenomenon were not really good. It was only now with the current deaths that we are again in the game for a mortality benefit. And the same thing can be shown when you compare it to surgery. You know that surgery has an advantage in mortality if you take all comers. And again, the same thing. The balloon came actually quite close to be to equipoise. But then things got worse because the first bare metal stent was worse. Even worse were the initial drug-eluting stents. And now we're getting again, with the current test, we're getting again competitive with surgery. So this is all shown by the figures. Now, just a few words about FFR. I said earlier this morning I've done only one FFR in my whole career. That was in the first patient. And I don't think it's a diagnostic thing that you should use. I know Bernie Gersh doesn't condone that. Now, what is FFR for me? You know, FFR for me is like you think something is wrong with your brakes. A patient comes in for a reason. Now, you gently test your brakes, and this is doing the FFR. This is gently testing your brakes. Now, if the FFR is normal, you say they seem to be working right now. So now you have two options, either option A and option B. Now, option A would you have your brakes fixed now. I would do that. I would do PCI. So I don't do FFR because I'm doing PCI anyhow. Option B is what Defer and FAME trial would suggest you wait until after the crash. This is Defer by FR. I don't think that's a good idea. I really don't, and I'll show you exactly why. Now, FAME 2 trial, as you all know, is not really a trial about FFR. It's actually a trial propagating that you should do PCI. What they did is patients with a abnormal FFR, they randomized between PCI and no PCI, and very surprisingly, but not to me, they found that those who came in with a problem and you didn't fix the problem, they had a 20% chance of coming back and wanting to have the problems fixed. That's pretty normal. I mean, if you bring your car to the shop to have it repaired, they don't repair it, it's quite likely you're going to go back to the shop to have it repaired. Those who had the car repaired here, they had only an 8% chance of having to come back for some reason. Now, what they completely misinterpret in the FAME 2 trial, in a pretty good journal, I have to admit, is the registry. They used the registry with normal FFR to prove that they did the right thing, because they said with the bad FFR, we could achieve by PCA is exactly what you get with a normal FFR, because for them, those people are not sick. They are healthy, which is nonsense, because they came to the hospital because they had a problem. Now, I submit to you that if they had done PCI on that group as well, they would have reduced their problem by half also. So they kind of deprived these patients of the possible benefit which they should have given them. So let me just finish this, and then I'll have some words about a few other things, how I see how you should use PCI at best, and I call this metaphor I use here the course of life, or if you blank out the O, it's the curse of life. Now, with every disease, but coronary heart disease is particularly apt to be shown here, when we start our life, we are put on this high plane, and we are constantly moving forward, and at some point in time we will fall off the cliff, but we'd like to have this at the latest possible moment, so we'd like to stay in the center. Now, coronary artery disease, as shown in the first patient already with the age of 38, he had his first lesion coming, and now, then of course with some drugs we could stabilize him, so we could have left it. But Grünzig decided to do this, and I think he did the right thing. And of course this patient had 2 other interventions, which is of course possible, but basically he was continuing on the center line. Now, the same thing here, again stable with 1 lesion. Now, FAME and Courage and other trials will tell you do nothing. The patient is stable and alive. That's the only thing they look at, is the patient stable and alive. Yes, this patient here is stable and alive, and this patient here is stable and alive. But imagine what is going to go on, even if there is no new lesion. If there is a new lesion, it's even an early demise, and if there is no new lesion, it's still an early demise. So that's not a good idea. So don't do FFR, don't listen to Bill Bowden and these folks. Just do your PCI. You're already there, and it's done now with the new drug-eluting stents with very, very little risk, and it takes 5 minutes less than doing the FFR. It costs not even a lot more. Now, let me just sum up PCI. We had the balloon, thanks to Grünzig, coming up in the sunlight, and we had so many things here. In the meantime, some of it was in the sunlight for a while, but they're all down below the clouds again, except for the stent. The stent is clearly an absolutely great thing, and we know now we have this sweating stent that gives out some medication, which is clearly a good thing. That's all we need for coronary angioplasty. Now let me just turn to other things. We know that coronary angioplasty seems to be the backbone of intervention cardiology. It was not the first thing. We see here that almost 20 or 25 years earlier there was already some interventional procedure done in a newborn, and even PFO and ASD closure actually was introduced before coronary angioplasty, but nobody talked about. The stent clearly, of course, is the only really important thing to add it to coronary angioplasty, and the next important thing is the transcatheter valve by Alain Cribier, and also the mitral valve, first done in Denmark, is certainly going to come and be very important because mitral disease is quite common. And also say a few things about LAA closure. I've already talked about. No, I don't say anything about it. I've already talked about it. Again, my depiction of intricacy and risk, you see that PCI may be very simple or very complex and has also a different risk. PFO closure, a preventive procedure, extremely simple, and so you do it even though it's only preventive. LAA closure, also preventive and risky, we don't like to do it. ASD closure, the therapeutic, TAVI, not really very difficult, therapeutic, everybody loves it. Some more intricate therapeutic procedures, we still do it because it's therapeutic. Now you should really love PFO closures because the device is already on your national flag. Looks like an Amplatzer device. Now let me just give you a few things about PFO closure. Some people know that this is really my pastime, and I'm on a mission to get PFO closure flying. Now you see that the Mayo Clinic, and Bernie Gershwer knows where that is, has shown this autopsy series on 1,000 autopsies, and they've shown that the older the patients who were autopsied got, the fewer PFOs were there, and they said that proves that the PFO closes throughout lifetime. That's one explanation. There is another one, and I, of course, prefer this one. There is selective mortality. You get weeded out if you have a PFO. You don't get an old person. Now, this was shown by our Danish colleagues. They just didn't realize. They showed that they published this in Lancet, and even the editorial going with it did not realize what they were showing. They looked at Danish patients, in a population study who came in with deep venous thrombosis or pulmonary embolism. So this is pulmonary embolism, this is deep venous thrombosis, and they were very surprised that they saw that while they were in for venous thrombosis, pulmonary embolism, they also had an MI and stroke. And so they said, well, that probably means they were stressed, and so they ruptured a plaque at the same time they had their venous thrombosis because of pain or whatever. They did not mention with one word the PFO, which explains that, some of the clots go to the lung, some go to the heart or to the brain. Very simple, completely missed in this paper and in the editorial. And it had been shown actually about 8 years earlier by a German group, where they looked at people who came in with pulmonary embolism and looked at whether or not they had a PFO. And they saw that the PFO was an independent predictor of mortality. So people with a PFO had a mortality of 33%, those without 14%, and this was, of course, all governed by paradoxical embolism, by MIs and strokes. And the Lancet didn't even cite this publication, which was 7 years old then. And actually, PFO saves lives. We have done a non-randomized study, but it was a study where the patients were randomly assigned to either PFO closure or medical treatment by neurologists, and the neurologists followed them up for 10 years, and the yearly mortality was significantly lower if the PFO had been closed than if the PFO had not been closed. So there is a mortality benefit, but you have to wait 10 years. And we know that the randomized trial in the United States, the RESPECT trial, even in the intention to treat analysis, showed a few things, that if you have a substantial shunt, if you have an atrial septal aneurysm, or if you only use aspirin in the conservative arm, there is a significant improvement in the reduction of stroke after PFO closure. And So if the alternative to PFO closure is lifelong oral anticoagulation, and who would not want rather a 15-minute procedure with no risk than lifelong oral anticoagulation? I think it's a no-brainer. You should offer that. The number needed to treat, of course, in the PC trial, also randomized trial, if you only looked at 1 year, it's 200. You have to close 200 PFOs to prevent a stroke in the next year. That's a lot, but those people live longer. At 40 years, it's only 40. At 20 years, it's 9. And at about 50, 60 years, only 2 PFOs that you have to close to prevent one stroke. And look at this picture here. This is my son and his fiancée. Now, I screened all my family for PFOs, and those 2 had one. Just by chance, it was a couple out of 10 screened people, 2 had one, what is about what you would expect. So they both got it closed in primary prevention. And you know, they spent 3 hours at the hospital. They got aspirin for 6 weeks. That was the only therapy they had, and this shows them the day after the procedure. They're pretty happy. I jokingly tell them that if they ever have a baby together, it will be born with the device. Now let me turn to TAVI, and I hope David is still awake, because we all know that we have shown that TAVI is a good thing. This is the 2-year all-cause mortality with maybe the second best TAVI that is on the market, a good one, but maybe not even the best one. And you can see that there is a mortality benefit, and those are randomized patients who could have surgery. So certainly, why should you not take the technique that has the better long-term survival? In addition, it has the better valve, because you can see that the surface, even at 1 year, and it goes out to several years, and the pressure gradient is better because the frame is smaller of the percutaneous valve. You know, the surgical valve has a pretty sturdy frame, and that takes away surface and increase the gradient. So you get the better valve durability nowadays, can be assumed to be the same with a much easier procedure. So not using TAVI in everybody, which I've been doing the last 3 years. I've not sent a single patient for aortic valve replacement to the surgeon. All got TAVI. If I needed a valve tomorrow, if I go before a heart team, I will get a surgical TAVI. I certainly don't want that. So I would avoid the heart team by all means if I needed a new valve. Now, TAVI surgery or not surgery is like this, again, metaphor. I like metaphors, as you found out. It's like you bought some new hiking boots. Now, with these new hiking boots, which would be TAVI, that's the new hiking boots, you climbed Mount Everest several times, not just once, but several times. They worked fine. Now you think about climbing this hill, because, you know, those are the very difficult patients which were treated very successfully with TAVI. Now you think, can I also treat a healthy 65-year-old like myself? You don't need to do a randomized trial to show that you can also use these hiking boots to walk up that hill after you've conquered Mount Everest several times. That is really where evidence-based medicine has no place. Again, I'd like to see this one-stop shop picture. Is another patient, 88 years of age. He had an LCX stenosis, aortic stenosis, he had atrial flutter, and bladder bleeding, so he got his LA closed, he got a new valve, and he got through a 5 French diagnostic catheter, even we put a stent into his circumflex coronary artery, and he spent one night at the hospital for this combined procedure. I mean, that is really great. And it's really something we can be proud about. Okay, thank you very much.